Thank you so much for the invitation and for the opportunity to present. I see some familiar names on the screen, so it's great to be able to connect with this group. So as was introduced, I'm going to tell you my journey in where we started and how I've come to realize that what we've been doing historically for decades was probably wrong, and how we get ourselves out of this mess to match our intent with what we do both clinically and in research. So I will disclose a couple of things. So one, I am chair of the Global Lung Function Initiative, as well as the American Thoracic Society PFT Committee. And so while a lot of the work that I'm presenting has been informed by these roles, the views are my own. And I do receive consulting fees from some various organizations for this type of work. So let's start with some history. Why do we use race-specific reference equations in pulmonary function? And what's the history behind why we perceived or why we thought that this was the right thing to do? So it is unquestionable that when we measure lung function in populations around the world, so people living in different geographies, people of different racial and ethnic backgrounds, genetic backgrounds, environmental backgrounds, we measure differences in lung function. This is data from the PURE study, which measured 30,000 people across 30 countries. And you can see very clearly an absolute measured lung volume. So this is no corrections for any equations. When we look at differences in the average lung function between populations, we see that people in South Asia, Southeast Asia have the smallest lungs relative to people in North America and Europe. And these differences are quite substantial. So 1.5 liters, almost 2 liter differences in men, and again, up to 1 liter different in the volume of the lungs between people of different populations. So when we look at populations around the world, we measure these differences. And so this is real. For a long time, I was taught this way. Many of us were taught this way. The perception was it's not people's lungs that are different. It's that their lung size relative to their standing height. And so what this essentially tells us is that two individuals that are of the same standing height, so full height, depending on their ethnic or geographical background, their body proportions are different. So generally, what we were all taught is that Black people have long legs relative to their standing height, and white people have shorter legs. And so two individuals of the same standing height, a Black individual will have smaller lungs because they have longer legs, and it's simply a difference in body proportions. So we see this in looking at population differences in the NHANES data. When we look at the sitting height to standing height ratio, this proxy of your chest dimensions, we see that Black individuals have longer legs relative to their chest size. And we see this again in children. So on the right-hand side of the graphs, these are children all recruited from the same area of London in the UK. And we see these classic differences in average body proportions. And when we measure lung function on the right, very far right-hand side of the graph, we see that the differences in body proportions mirror those differences in lung function. And so we've kind of seen this correlation and assumed that it's causation. We've assumed that the differences in lung function are explained by these body proportion differences. We also had studies, this was a prominent study that was published in the New England Journal of Medicine, showing that these differences in lung function that we observe between populations are correlated to the percentage of African ancestry. So the more African ancestry that you have in your genetic profile, the smaller your lungs are. And so these two pretty prominent perceptions or evidence were used to justify and have a scientific backing for why the differences in lung function that we see between populations are biological, that they are related to these measurable differences in body proportions or genetics. And in the United States and around the world, the practice of correcting for lung size, acknowledging that there are differences in lung function between different populations, is enshrined into law. So in order to avoid discrimination of Black individuals from employment, and I think this is relevant to the occupational setting, NIOSH originally imposed this correction factor, or was said to multiply the white predicted values by 0.85 and then interpret the results of Black Americans with this correction factor. And I want to acknowledge that even at the time of writing back in the 70s when this was proposed, it was already acknowledged that these ethnic differences or population differences may be due to lots of extrinsic factors like social determinants of health, and it was not a unanimous or consensus decision that this should be done at the time. And so in the 90s, and then followed on by the Global Lung Function Initiative, the overarching feeling was that we shouldn't have these blanket correction factors. Number one, there's lots of diversity in the world's population, so correcting everybody by 0.85 didn't seem right. It also didn't seem right that we only measured lung function and created reference equations for white populations and then applied these correction factors. So John Hankinson was very astute at the time. He said, let's actually go out and measure lung function in a very diverse set of people. Let's overrepresent our NHANES sample with diversity of populations so that we can actually create reference equations based on the data collected in these individuals, not have a white equation and correct it for a fixed cutoff. And so the work that John Hankinson did was revolutionary in one, having a single standard so that every lab across all of the US was using the exact same reference equations. And rather than assuming corrections, we had data and created, in that case, ethnic specific or race specific equations based on data. Philip Quanier and the Europeans were very upset about this because it was only for the Americans. And so the Global Lung Function Initiative was established to do essentially what John Hankinson did in the US, but to create a global standard where we would equally have reference equations derived from people of different ethnic groups based on large and representative samples, and where we included more diversity than just Black and white equations like we had in the NHANES data. And so in 2012, the GLI published our ethnic specific equations, where we had equations for white individuals, Northeast Asian, Southeast Asian, and African American individuals. And over time, the GLI became the default standard because it was global instead of just for the United States population. But essentially, there are two populations or two studies doing very much similar things. Around that time, a prominent sociologist named Lindy Braun was looking into this practice. She was looking into the history of spirometry and published this book called Breathing Race into the Machine, where she chronicled the history of how spirometry was used historically to justify differences between populations, between Black and white individuals, to justify the inclusion of Black individuals into slavery. She highlighted how over history those ideas were perpetuated and still used today. And I will be very frank and honest that when we first saw Lindy Braun's book and when the New York Times published their 1618 chronicles and called out pulmonary function, I distinctively remember being at an ATS meeting and we all said, oh, but we're different in pulmonary function. Like this is not us. We're doing this based on science. We're doing this based on improving equity, and we have a good rationale for why we're doing. So we considered it and initially dismissed it. Subsequently, over the next few years, not just in pulmonary function, but it became very evident across the medical field that there were approaches to how we define disease, how we interpret results, how we develop prediction algorithms, where race and particularly Black race was being used as a biological measure, when in fact it was being misused in perceiving that these differences between populations were biological rather than accumulative of the social determinants of health, accumulative of the lived experience. And it was this is a editorial or perspective that was published in the New England Journal in 2020, where a group of residents looked systematically at what they had observed in their medical training and looked at all of the different ways in which within clinical medicine, race corrections or race algorithms were being used to interpret clinical data and where they could be potential bias. And we've really come to recognize this hidden in plain sight. Once you open your eyes, we see it everywhere. And when this article came out, the ATS asked our PFT committee to commission a working group together with the health equity group of the ATS to really evaluate what we were doing and whether what we were doing was scientifically sound. And so I draw your attention to two documents that were published. The first is the official statement from the ATS about the use of race and ethnicity in PFT and reference equations. And the second is a joint piece between ATS, CHEST, the Canadian Thoracic Society, and AARC, looking at the kind of future and the research gaps in these areas. So I'm going to switch gears and show what those meetings and those deliberations and our discussions led to, and why, as an organization, and many of us as individual researchers and clinicians have decided that what we were doing with the best intent actually had harmful consequences. So the first thing that we questioned is that we assume in a lot of what we do that we know what normal is. When we apply these reference equations, when a clinician gets a PFT report or a patient gets a PFT report, we assume that that comparison is to an absolute health or a clear definition of health. And what we do in pulmonary function is far from that truth. So when we create reference equations, we are identifying people that are otherwise healthy. So they don't have a doctor diagnosis of lung disease, they are non-smokers, and they don't have symptoms at the time of testing. We recognize in creating these reference equations that a group of individuals at the lower end of that spectrum may have underdiagnosed lung disease, may have early lung disease that doesn't quite meet those definitions or are mislabeled. We also know that there is a considerable overlap with disease. And so we know that there are people with established lung disease who will fall into that normal range. So we see on their CT images that they have emphysema or bronchiectasis or various pathologies that are very obviously lung disease, but their spirometry results are normal. And so there's this considerable overlap between our definition of health and our early lung disease that we don't take into account when we are interpreting the results. We assume whether you're using the fixed ratio of 0.7 or the lower limit of normal, these are two approaches that assume this absolute health disease, this binary definition, when actually there's quite a spectrum and quite an overlap between them. Within our white population, we assume that these individuals that are included in the NHANES or the GLI are healthy and will remain healthy. These are cross-sectional samples that at that point in time, the individuals were non-smokers, didn't have lung disease, were asymptomatic. We don't ever look to see whether they go on to develop lung disease. And this work by James Allison, where he looked at 100,000 individuals over 100 years of data, all white European populations, these cohort studies, and he looked at successive cohorts, so looking at birth year, and when you were born relative to when you had your lung function measured. And he shows very nicely that over 100 years, we've had, again, a 1 liter improvement in our lung function in the same white European population that we assume is fixed. So even in our healthy definition, we have cohort effects or improvements over time that we don't include or think about when we interpret lung function using these approaches. And we also know that there is a strong socioeconomic gradient with lung health. So this is data from Samsonapa in India. So what she looked at is she looked at the Indian subcontinent and children that were born there. And she looked at children of Indian ancestry who were living in the UK. And we see that their lung function is very similar. So first, when we look at this, we might assume that these are real ethnic or biological differences because two children living in the UK and India, we would expect them to have different lung function. But when we look at the socioeconomic gradient, so within that group in the UK, living in India, we see that there's a strong gradient between urban and rural populations, with urban populations having better lung function than those rural populations, and obviously huge overlap in these results. And this is not unique to the developing or low-income countries. This is work out of the US published in CHEST showing that when we look at age-adjusted FEV1, in both men and women, there is a very strong socioeconomic gradient where the lower socioeconomic groups have the lowest lung function overall. Recently, we worked with a group in China. They had gone out and measured 30,000 people in a large representative sample from all across China. We compared that raw data that was collected, these are the green bars on this graph, to what we would have interpreted using GLI equations. And we see that in individuals living in China, a contemporary population where we looked at good quality data, we did everything similar to what would have been done in an NHANES survey. And we see that people living in China, both North and South China, that their lung function is very similar to what we produce with the GLI Southeast Asian equations. And actually that if we had interpreted using the Northeast equations, everyone would look much sicker than they are. But I purposely put this picture in the background of air quality in many urban centers around China. We can think about early life determinants, poverty, pollution, nutrition. And I wonder whether when we say that there are these population differences in China and that on average they have much lower lung function than what we see in Europe, is this really all biology? Or is the environment that children grow, that lungs develop, the cumulative exposures along the life course, what are we measuring some of these cumulative exposures in our measurements of lung function? And are we artificially calling this normal? Are we allowing that people who live in these kinds of conditions and have these early life determinants, that when they reach adulthood, it's perfectly normal for their lungs to be smaller or their lung function to be lower than what we would expect of populations in Europe? And how do we disentangle what's truly biology, genetic, versus those environmental and social influences that we know from decades of research into this that influence lung health? So when we think about these population differences, we have to consider some of the more epidemiological or conceptual ideas. So we have a selection bias. Already when we create these reference equations, we are subselecting people that we define as health, and we define health as the absence of disease or the absence of symptoms. And we know that there is major issues in terms of access to healthcare, access to diagnosis. We know our most marginalized populations are the ones least likely to have a diagnosis, to have access to healthcare, and they could be artificially called as healthy in these large population studies when in fact they're not. Many of the population-based studies, we use different equipment, different protocols, different quality control, and we haven't, despite all the work that ATS and ERS have done, we haven't quite ruled out this measurement error that we know exists in how we measure lung function. None of the studies that we look at where we define health, where we define reference equations, compare air quality, look at nutrition or respiratory infections in childhood and across the life course. Lindy Braun nicely showed that 94% of the studies that showed differences between populations did not account for any measure of the social determinants of health. And we also know that the environment, including temperature and altitude, all interact with air quality and these factors. And none of the studies that we have done look at these things comprehensively. And finally, all of these studies have looked only at height. And we know that height, while very strongly correlated with chest size, is not a very precise measure of chest size. And we know that even in two individuals that are of the same ethnic or racial background, that you can have two individuals of the same standing height that have very different chest shapes and dimensions. We've also come to recognize that race is a socio-political construct. And actually, when this started coming up and we were asked to respond, I went back to all of our original GLI work, our original publications, and we have always recognized that race and ethnicity are socio-political constructs. And we've used these genetic differences or differences in body proportions as proxies for these social determinants. And I think that that assumption has not been based in science. And when we look more critically, not just in the United States, but globally, we know that the use of race is strongly linked with racism, structural racism, and we've ignored that in how we look and interpret the data. We also have an issue that race and ethnicity are not unifyingly defined across the world. When I talk to people at the pneumotac, the people doing the testing, they tell me that asking somebody about their race and ethnicity is the part of the job that they hate the most because they don't know what box people fit into. The boxes that we have are arbitrary. They don't reflect the diversity of the world's population. And the vast majority of people don't fit into the neat boxes that we've defined to define these groups. So what ends up happening is people who we know are white go in the white equations, and everybody else falls into the other equation of the I don't know what group we're in, or I don't belong to one of the groups that you have. So we've had this dichotomy or two standards that we're applying. We've seen that over time. I showed you some data from Europe. The definitions and how we perceive these social constructs changes over time. I'm going to show you some data in the next set of slides where we're actually masking potential risk factors. We might be calling normal impairment or we're calling impairment as normal when actually there may be opportunity to intervene and improve somebody's lung health. Despite that seemingly convincing data about the correlation between genetics and lung function, we now better know that race is not a proxy for genetics. There is no gene for race. And when we look at genetic admixture in diverse and global populations, we see there's more genetic diversity within the African continent than there is between populations around the world. So this idea that we have a genetic determinant of African ancestry is flawed and very much in the genetic side of things being questioned and not used or perpetuated. And I'll share some additional data especially in pulmonary medicine. We cannot ignore the history. We cannot ignore that how we came to how we use race-specific equations today is based on historical data where these racial differences in lung function were used to justify innate inferiority, where we did have written into US law and into our clinical algorithms these perceptions of biology that were not real. And so going back to some of the previous data, it was studies like this by Benjamin Gold that showed that Black Americans had lower lung function relative to white Americans, and that this is when race was baked into these assumptions and what was used to perpetuate the idea that these differences were real or biological. And even back then, Benjamin Gold recognized that it was very difficult to put people into these categories, yet they persisted. When we think more globally and holistically about the factors that influence lung health, the things that we include in our reference equations, standing height, age, and sex, are only a small portion of the numerous factors that we know interact and affect lung disease across the life course. And genetic admixture and race are a small component of that. There are many other factors that equally apply to people of different racial and ethnic groups everywhere in the world, and we ignore many of these factors. And so for the last piece, I want to highlight the evidence that we used on the ATS Committee for Pulmonary Function to make this recommendation to use race neutral now. Again, these are used by many names, GLI Global, GLI Race Neutral. Again, I'm going to be very transparent. These are not the final solution. These are a Band-Aid. This is an opportunity for us to recognize that what we were doing was wrong. And it buys us time to come up with better evidence-based, data-based approaches to how we interpret lung function. So let me tell you what happens when you switch from GLI race specific to GLI race neutral. It'd be no surprise to anybody that we're going to get a shift in our equations. On the left-hand side, you see the race-specific equations, and by design, they shift all of the populations, in this case, the Black populations, such that they have a normal distribution of their lung function. When we apply race neutral, we see the Black population gets shifted left and the white population gets shifted right. So white individuals on average will have better lung function when we interpret their lung function. So they'll have higher percent predicted values, higher Z-scores, and the Black population will have lower percent predicted, lower Z-scores. This is just because we've changed where that line is. We've just moved where our comparison line is. What that means is that we'll see people shifting in terms of their categories. The biggest shift that we'll see is in the people that are labeled as having restrictive lung impairment. This is based on FVC alone. So we will have more Black individuals will have lower FVC values. Fewer white individuals will have lower FVC values. Now, remember that in spirometry, we don't use spirometry to diagnose restrictive lung disease like IPF or other restrictive conditions. This only gives us a clue that the lungs are small. Spirometry and a low FVC can be low for many reasons. It could be a poor effort. It could be a muscle strength issue. It could be true parenchymal lung disease. It could be due to extrapulmonary reasons. And so this low FVC is going to give us an idea that there may be a restrictive pattern, but we don't use it to diagnose restrictive lung disease. When we look at potential changes in who will get referred for lung resection, we see that Asian and Black individuals now are going to be less likely to be recommended for lung resection. So they're going to potentially have new barriers. And white and Hispanic individuals will be more likely to be classified. Our group looked at some data and we went back to where does this 30% recommendation come from? How do we reconcile this evidence with our intent? And when we look back at the evidence, these are studies based in the 1950s and 60s where based on very small numbers of individuals, these thresholds of 30% were derived. If we think about how we develop clinical algorithms today, those data, those studies would not stand up to our evidence. So when we talk to the Veterans Administration about these data and about potential implications, I think when we switch these equations, as I said, they're a Band-Aid. It highlights to us that we have to think about what we're doing. We must go back and revisit these cutoffs. We need to understand we need to match our intent with our purpose and ensure that what we're doing is equitable. Again, this is for referral for lung transplant. The lung allocation score, at least in the US, no longer uses lung function to determine allocation, but we certainly know that people are still referred for lung transplant based on their percent predicted. And again, as expected, we're going to see fewer white and Hispanic individuals referred for lung transplant and more Black and Asian individuals recommended. There's a really nice piece in the New England Journal from last May that applied the transition to the GLI global or race neutral equations across ventilatory impairment, occupational eligibility, COPD severity, as well as disability payments. And again, as we would expect, there would be big differences in terms of the absolute number of individuals that would be classified according to these new classifications. But as a group, we wondered, well, does it matter? What is the truth? What are we trying to do here? We're trying to come up with better and more equitable ways of identifying lung disease in populations. So we've assumed when we do all of these comparisons that what we did previously was correct, that the race-specific approach was the precise or more accurate way of looking at lung function. And that, again, couldn't be farther from the truth. So let's re-examine the evidence in terms of whether or not the race-specific or the race-neutral approach actually matches what we want to do. So back when lung function was first being measured, these social differences in lung function, the socioeconomic gradients were already observed. When we go and reevaluate the evidence about those body proportions and the chest dimensions, we went back and looked at all of the studies that had measured both sitting height and standing height, as well as socioeconomic status. And we see the percentage of differences in lung function that are explained by socioeconomic status are equal, if not greater, to the proportion that is explained by sitting height and standing height. So the evidence that the differences we observe between populations is because of chest dimensions is not based on the data. When we reanalyze the NHANES in trying to incorporate sitting height, it did not fix or did not explain, did not give us better reference equations than if we use standing height. And that's because even within ethnic groups, there are white people with long legs and white people with short legs, and vice versa across all ethnic groups. And the same factors, the socioeconomic factors that influence lung growth and development, also influence our somatic growth and body proportions. When we look at survival, on the left-hand side, these are NHANES data. When we apply ethnic-specific equations, we see the predicted survival is higher for white individuals than Black individuals. When we apply race-neutral equations, what we see is for the same level of measured lung function, the probability of surviving is the same for a Black or white individual. So we were underestimating the risk of mortality in Black individuals when we used race-specific equations. And I know many of you are thinking, but we don't use lung function to predict mortality. So let's look at symptoms. So this is Aaron Braun's work looking at the St. George's Respiratory Questionnaire on the top and the COPD assessment score. So when we use race-specific equations for the same level of symptom burden, African Americans have better lung function using race-specific equations. On the bottom set of the graphs, when we switch to a race-neutral approach, we see that for the same level of symptom burden, the predicted lung function is much more similar between Black and white individuals. So the race-neutral equations better match to symptoms. We also look at implications for classifying COPD and predicting exacerbations. So again, Black and white individuals using GLI global or race neutral, we know that more white individuals will be reclassified as having mild COPD, and more Black individuals will be classified as having more severe COPD. But I think this is the most important result. Those individuals that are classified as having higher disease severity using GLI global actually have more exacerbations. Those individuals that are classified as having lower severity have fewer exacerbations. So using a race-neutral approach actually matches with the prognostic indication of whether or not they're going to either have COPD exacerbations or all-cause hospitalizations in those individuals with COPD. Again, we know there are going to be shifts. We know that we're going to be reclassifying African Americans to have more PRISM, to have more restrictive patterns, to have more disease severity. And I don't want to say this is simple math, but again, we're just changing where the bars are. And we know that there are going to be people that are reclassified according to these groups. And thinking about the lung allocation score or how people will be influenced. So if we use the race-specific approach, You're going to have lower priority for Black individuals and higher priority for white individuals. And the opposite is true when we use race neutral approaches. And so we're becoming more equitable in how we define who is eligible for these treatments. And it's not all bad news. And I know that it is logistically challenging and cumbersome to switch equations. There are multiple services that refer into pulmonary function labs. There are community services that are affected. And the last thing that we want is every pulmonary function lab doing something different. So I can reassure you that our main purpose of using spirometry is to identify airflow obstruction. And so we know that when we look at the FEV1 FVC ratio, that this is much more similar between populations. When there is a reduction in FEV1 or FVC between populations, it happens proportionally, such that we are still very good at picking out airflow obstruction using the ratio, and this is robust to reference equations. And if I have time, I think I have time, I can go through a couple of examples, clinical cases, so that you can see what this would look like in practice. So this is a 57-year-old individual who presents with a persistent cough and dyspnea on exertion after a COVID infection. There's no significant medical history other than they are a former smoker, and they have been using short-acting beta agonists with minimal relief. So we look at their pulmonary function. I'll just orient you here. So we have their flow volume curve and their volume time curve. We have their measured or actual lung function, the predicted value, the lower limit of normal that we would use to differentiate if they're outside of what we would expect in healthy individuals, and their percent predicted. So what we see is that their FEV1 FVC ratio is above 0.7, as well as above the lower limit of normal. So they are within the normal range. And their FEV1 and FVC are both reduced. And on this pictogram on the right, you can see that they're reduced outside of that normal range. So based on this result, we would have classified this individual as having a preserved ratio with reduced lung function or reduced FEV1 with a history of smoking. And so this is the same individual, but now we've changed the prediction equation. And so looking at the result now, they are still not, they don't have airflow obstruction using the FEV1 FVC ratio. And we see that now they've actually improved such that they are no longer below the lower limit of normal. And we would have identified this individual as normal. The only difference between so there's no difference in the actual measured values. So you can see in all of the measured values, the results are exactly the same. The difference in interpretation is whether we use the white equations for this individual, which would have identified PRISM. If we had used the black equations from GLI, it would have identified the individual as normal. And if we use the GLI global, again, we would have still identified this individual as having PRISM. And so based on which equation is used, we may very well come up with different clinical decision-making. We may send this person for additional testing or further referrals, or we may send them home as normal. And so what I want to bring back is that these results highlight that we have the zone of uncertainty. Interpretation of lung function is not black and white, pardon the pun, it's not normal or abnormal. We've artificially created these dichotomies, I think for good reason. We want simple algorithms that we can apply in practice, simple rules that help us make these decisions. But all of this work has highlighted to us that there's actually this very wide zone of uncertainty. And depending on why the person is in the pulmonary function lab having the test, somebody in this zone of uncertainty where they're maybe above the limit of normal in one equation and below in the other, in all of these cases, we're not certain that they have a disease. We just know that they're in this zone of uncertainty. think this is where we need to be more judicial in how we approach these individuals. These are individuals that we would bring back for another test. These are individuals, if they have a significant medical history or significant symptoms, we would bring them in for additional testing, maybe a CT scan or other tests to try to differentiate what's happening. That doesn't mean that everybody should get a CT scan, but I think that rather than getting a PFT report and looking at whether the numbers are above or below a certain line, we need to be looking at a PFT report in context of that individual, in context of why they're there and what their medical history is to make the right decision for that particular individual. And so again, remembering that an isolated reduction in FEV1 or FVC is helpful in ruling out restrictive impairment, but insufficient to rule in a particular restrictive disease. And a low FEV1 can tell us a lot of things. A low FEV1 is actually the single most best predictor of all-cause mortality, of cardiovascular mortality. So having low lung function isn't a normal trait. There's something that it's capturing, but we don't know if it's capturing our cumulative life experiences and telling us about someone's overall health and therefore is prognostic of mortality, or whether a low FEV1 on its own is pathophysiological and potentially amenable to interventions. And I'll close just by saying that our colleagues in endocrinology have started questioning BMI and how BMI is used. And similar to that argument, I don't think we should throw away spirometry. I don't think we should throw away FEV1 or stop doing what we're doing. But I think we need to be more cautious and think about all of the downstream ways in which a lung function test is used. Should we really be deciding how much disability payment somebody gets based on a measured lung function value? Can we use other tools and more comprehensive assessments to identify a more equitable way of assigning disability? We all know how variable lung functions is. We know that our patients are shopping around for labs where they get the lowest results, so they get the most compensation. I think we can do better in how we use these tests, both for clinical decision making and also for all of those downstream ways that lung function tests are used. And so I'll close there. So we have lots of time for questions. But again, I really appreciate the invitation to present. I don't have all of the answers, but I hope that I've shared with you why I think we do need to revisit and rethink what we're doing. Thanks again for listening today.